Hi, my name is Patrick Murray, and I'm the director of the Polling Institute here, who along with the School of Nursing and Health Studies and the Political Science Club is the sponsor of this event tonight. Very timely, and I'm sure knowing who the panelists are up here is going to be very provocative. A couple things that I just want to say: make sure you turn off your cell phones, ringers, whatever. Also, some of you may have already submitted a question and answer card, but you might have some questions that pop up. So if you have a card or we'll be around, we'll be collecting them to give to the moderators at somewhere midpoint in the event tonight, so that they'll call on you and we'll come around with a microphone and you can ask your question that way. And so just make sure you hand the card to one of the staff that's roaming around here today. The other thing that I wanted to just mention before I turn it over to President Brown is I always have to mention something about polling anytime we go into any event that I'm involved with.
I might as well sit down.
Yeah. So this is, we have been polling about the Affordable Care Act here in New Jersey over the past year and a half. Early on, most people in New Jersey didn't know about it. I'm sure that's a question that we'll talk about in terms of the exchanges, the state versus the national exchanges. But in the early days, it was 45% favorable to 40% unfavorable, with a lot of don't knows. And then they started enrolling people, and the website crashed, and it was 40% favorable to 50% unfavorable, and fairly stayed that way for a few months. When we last polled, it was more even back in the fall, 45% favorable to 46% unfavorable, and that's the opinion of all New Jerseyans about the Affordable Care Act and what it means to them. So we'll hear a little bit more about that today. But right now, I'd like to turn it over to the president of Monmouth University, Paul Brown, to welcome you.
Thanks, Patrick. Thanks. You know, you give your best friends the hard time, and Patrick, it's great what you do in terms of the Polling Institute. We absolutely love it. Let me also say how incredibly pleased I am that we're here together. I think it's an incredibly timely panel. It's a topic that really needs some attention and can't have too much attention. It's an important topic, I believe, to everybody in the room here today, because whether we like it or not, we all need health care and we all pay taxes. Everybody pay taxes? Okay, so we're spending your money. Health care, I do think of it from the context of it's truly a universal issue. We think about it on a personal level. I often think about it on a very personal level, particularly with family. And then, of course, you think of it on a personal level with yourself. But the political aspects of it are so complicated. Wonderfully complicated, because that's our world, but complicated. So we really need to be thinking about a panel that can help us. And I think we have an outstanding panel of experts who I think you will agree. Real practical implications of what we're addressing is a really important aspect. Significant recent changes in public policy initiatives. Obviously, the Affordable Care Act will be the legacy that we'll be following, and it will be signed into law, and was signed into law just 5 years ago. Seems like just yesterday, but it is 5 years ago. In that context, let me also say everybody is great to have here, but I'm always biased towards former governors. I mean, who isn't? So thank you, Governor Florio. It's great seeing you again. We've had the luxury of having the governor with us all throughout the academic year. We think it's really important to have public servants in residence. We have a very robust program. And the governor has been our public servant in residence for 2014, 2015, the academic year. And he's not finished yet with his shtick. So there will be more to come. And it's great that you're with us. Let me also say it's so much a pleasure to see many faces I recognize here. That's also nice, really special. Students, you're what it's all about. That's what's great. It's what's great about higher ed. So it's really nice having you all here, and particularly with thought leaders. I've known Frank early on coming to Monmouth. You were very gracious to welcome me to the community, which is great. And John, we've known each other. You're a confidant in arms. You support us, and that's really special. And Ward, it's so nice getting to know you. Thank you very much for being with us. Monmouth University continues to grow, I think, in many areas, but the areas of public policy in particular, it's absolutely one of our strengths. Public policy, the diverse array of healthcare-related programs we have. With my faculty colleagues here, I'm always remiss to start saying the programs, because I'm sure I'll miss one, and I'll see the steam come out of the ears of that faculty member that I missed that program. But that's a nice problem to have. We have so many programs, what I think of as in the healthcare and wellness area broadly defined. And when you think about it, it's probably 45% plus of what we do is in that area, which is fantastic. And of course, it's led by lots of faculty, and that's great. Let me also say that the quality of the classroom instruction, I know, is what's crucial to make these programs work, and I know the faculty think about that all the time. There really is no substitution for the learning directly from the experts in the field. And I think about that in the disciplines that I know so well, and these are disciplines that are really special, and you must have experts in the field right there, and you do that. Also, Patrick reminds me, and it's a really good point, we really work hard at interdisciplinary events. It's really important to think about breaking down silos. This is terminology that's used in higher ed, but there are silos in your organizations, I know you know, and we have silos in our organization too. And we really have to go across those silos. So we have the Polling Institute, as Patrick just said, playing a front and center role in this area, helping with the debate, helping with the dialogue. We have the Marjorie K. Unterberg School of Nursing and Health Studies, playing a really wonderful role. And of course, the Political Science Club. Now let me see the hands of the students that are in the Political Science Club. Now I know that club. You're the best. Now I say that to every club, so when I'm with the athletes next week, I'll say that too, but you are the best. You're really great in terms of what you do. So it'd be great to hear what our colleagues have to say. We have moderators that'll really help make this work, and that's what's really great. Kathryn Fleming, who's a specialist professor of nursing administration. That's great. She's also a nurse scientist at the Ann May Center of the Meridian Health System and vice president at the New Jersey State Nurses Association. Keeps you busy. And Dr. Stephen Chapman is an assistant professor of political science and sociology whose research interests focus on particularly state-level representation. And that's a really interesting emphasis that clearly we can benefit from here. So why don't I do the following? Why don't I thank both of you for everything you've done. What you'll do is you'll put these gentlemen to work. You'll put them on the spot. You'll get some good answers, and off we go. Thank you very much for being with us.
Well, thank you everyone for coming. I just want to take a second and thank all the students, faculty, and staff for attending. Special thank you to our panelists. The way it's going to work, we'll just go through some short introductions, and then we'll jump into the first question.
Okay. So the first introduction is the Honorable James J. Florio, served as governor of New Jersey from 1990 through 1994. As governor, he was responsible for signing into law the Clean Water Enforcement Act in 1990, one of the strongest environmental laws of its type in the nation. He also represented New Jersey's 1st district in Congress from 1975 to 1990, where he authored the Superfund Law, our nation's primary program for cleaning up hazardous waste sites. He is also an expert in the area of healthcare and has served on numerous boards of healthcare organizations. Governor Florio was the 1993 recipient of the Profile and Courage Award by the John F. Kennedy Library Foundation. Welcome.
Our next introduction is for Wardell Sanders, Esquire. He has been president of the New Jersey Association of Health Plans since 2006. NJHP represents the state's major health plans, including 4 Medicaid plans. A recognized expert on healthcare policy, Mr. Sanders served in state government for 15 years, where he was executive director of the New Jersey Individual Health Coverage Program Board and the New Jersey Small Employer Health Benefits Program Board. He has also served on the state's mandated Health Benefits Advisory Commission, the Healthcare Access Study Commission, and the Medical Care Availability Task Force.
Next, we have John Lloyd, is President and Chief Executive Officer of Meridian Health, encompassing Jersey Shore University Medical Center, K. Hovnanian Children's Hospital, Ocean Medical Center, Riverview Medical Center, Southern Ocean Medical Center, and Bayshore Community Hospital. Under Mr. Lloyd's leadership, Meridian Health has grown and evolved into a nationally recognized healthcare leader with a special focus on clinical quality, nursing excellence, and innovative technology applications. Meridian's Accountable Care Organization was established in 2013 to serve Medicare patients. Mr. Lloyd has served as the chairman of the New Jersey Hospital Association and holds many board and leadership positions. Welcome.
And finally, we have Dr. Frank Vozos. Dr. Vozos first came to Monmouth in 1975 as a resident in general surgery. In 1998, he became only the second physician in New Jersey to take on a top hospital leadership role when he assumed the position of executive director of Monmouth Medical Center, a Barnabas Health facility and one of the state's largest teaching hospitals. Dr. Vozos also is a member of the Board of Trustees for the American Red Cross, Muscular Dystrophy Association, Jersey Shore Partnership, and Prevention First of Monmouth County, among many other organizations. Dr. Vozos is a fellow of the prestigious American College of Surgeons and a diplomat of the American Board of Surgery, and he also served as a member of the New Jersey State Trauma Committee. Welcome.
Okay, each question is going to be directed towards one of the panelists with an opportunity for all members of the panel to respond. The first question is to Governor Florio. How does the ACA align with your position on health care? And a second part, did the ACA do too much or not go far enough?
Well, thank you very much for the invitation. I'm pleased to be here, particularly with all the people who are going to be talking. I think it's fair to say that the ACA attempted to deal with, and attempts continuing to deal with the limitations that we have in our healthcare system. Healthcare planners always talk about the ideal system being one that brings into balance cost, quality, and access. In those areas, clearly there's a need for focus. Cost, as I think most people know, has been out of control. I mean, at one point we had healthcare costs representing 18% of gross domestic product. That's the product of all of the results of all of our goods and services. Think about that. That's 1 out of every $5 goes to healthcare. That's just unsustainable for a long period of time. So cost is a very important thing for us to deal with. Quality, we have a great quality of healthcare in this country if you can afford it. So people who are at the top of the income level have access to good quality, but people at the bottom don't have really good access to quality. And that goes, the whole question of what healthcare is a very important philosophic question. Is healthcare a commodity, like a TV or a shirt? If you can afford it, you can have it. If you can't, you can't have it. Or is it a right, and as it is in most other industrialized countries, an entitlement that people are entitled to? And then the question of access is a really hard one. That's the one that ACA is primarily trying to deal with. At one point not too long ago, we had 50 million Americans with no access to health care. People who were not old enough to be on Medicare, not poor enough to be on Medicaid, didn't have it through their employment, and couldn't afford the $11,000 or $12,000 for an individual health care policy out of their income. So those are the types of things that we're trying to deal with, and the ACA is trying to deal with it. We'll talk about whether they're succeeding or not, whether the system is good enough. But I think it's a good agenda for us as a nation to be able to undertake.
Okay, wonderful.
Would any of the panelists like to respond to that? Adam?
Well, I think the question went to what hasn't been met, you know, and I guess the one thing that has been hanging out there that I see as the greatest continuing barrier to care is affordability, and the law does some things to try to get at the cost challenge. You know, over the past 30 years, there's been a number of reforms. Governor Florio signed a number of them in 1992. Groundbreaking reforms for New Jersey that I think were, on whole, you know, excellent and did a lot of good for people of New Jersey. And a lot of states followed, and the Affordable Care Act followed in many respects what New Jersey did in the early 90s. But the greatest challenge then, and the greatest continuing challenge, is cost. Medicaid is a program for mostly lower income folks. But it does have income levels. There are folks that then can afford or that are eligible for subsidies through the Affordable Care Act. But there's still, even after the Affordable Care Act, are folks that can't afford coverage, can't afford some of the deductibles or coinsurance or copays that they have. So I do see that the last great barrier is the one that we've been keep banging our heads against, which is affordability, which is not completely addressed really in the Affordable Care Act.
I absolutely agree with that. The cost of health care is still escalating far too fast, and a lot has to be done with it. We've always believed at Meridian that as a country, we should have been ashamed of ourselves that we didn't have health coverage for everybody in the United States. And we're on a journey now, which I think is very positive. Obviously, we've had our challenges getting the exchanges off the ground, but we're starting to see some pretty good success in terms of getting more Americans covered. And I think that's something that all of us should and can support.
I would add to what John said that there is a difference between teaching hospitals and non-teaching hospitals in terms of providing access to that care. And I know at Monmouth Medical Center and similarly at Jersey Shore Medical Center, I don't think anybody has ever been denied care, and they do have access to care. And unfortunately, whether it's because they are underinsured or uninsured, they actually must come there and have been able to use our emergency rooms or our clinics to receive that care. And one difference I think I will say is that there is that perception out there that those that are at the lower level of the income stream or who don't have insurance receive a lower level of care. I will tell you at a hospital that's a teaching hospital, that's not the case because the people that are manning our clinics and our emergency room are actually faculty at local medical schools, and they are teachers of the residents that are being trained. So in a way, I would argue sometimes that they may get a higher level of care than some of the people out in the community are getting because they do have access to these highly trained and highly educated individuals.
That brings up actually a really good point. It alludes back to something Governor Florio said about, do we think of healthcare as an entitlement or is it a commodity? And I just want to know if what your thoughts are on this for all the panelists.
Well, we view it as an entitlement. And that's because, as I said before, nobody ever gets turned away. And I think everybody that comes to us, regardless of their ability to pay or what their insurance status is, pretty much receive the same level of care. We actually pay attention to that. We pay close attention to that. We don't want to be giving two standards of care. Even when we try to develop an area of the hospital that might be a little bit more upscale, private rooms and all that, we don't reserve it only for those that have good insurance or can pay, have a better ability to pay. So I would look at it as an entitlement.
I would just make the observation, and I think the points make the connection between the various facets that I talked about, affordability and access. It's commendable that many of the hospitals, most of the hospitals, take uncompensated care patients, that is people who can't afford to pay. The hospitals give them service, but then the question is, who is actually paying for the people who are not getting the coverage? Everyone pays, because the hospital rolls into the rate base or the cost of the uncompensated care in excess of what they get from taxpayers in uncompensated care. So everyone who pays their premiums in their insurance are eating the costs that are not paid for by the people who haven't got coverage.
In a way, I mean, the philosophical question posed, I'd agree with the comments of the governor and the doctor that, in a way, we do have universal health care. It's just poorly organized. The notion that, the emergency room is the first place that people will go is not the right care at the right time at the right place. Hopefully there's a movement away from that. Hospitals are doing a lot of hard work, and my friends at the Hospital Association and many hospitals are trying to move away from that model. But it's an important challenge, and I think some of the promise of the Affordable Care Act was that this would give folks access to coverage with primary care physicians so that they could receive care in that appropriate setting rather than going to the emergency room for all their care where they must be treated.
Thank you. So we'll move on to the second question is directed towards Governor Florio as well, and it takes more of a legal perspective. So we've already seen one challenge to the Affordable Care Act pass the Supreme Court. There's another one on deck with King B. Burwell. For those of you who aren't aware, that's dealing with the state exchanges and how they're set up. So I was wondering if you had any idea if that Supreme Court case would have any effect on the long-term effects of the Affordable Care Act.
Well, there's always a hazard in trying to figure out what the court is going to do, these types of things. But it just seems to me that it's a standard principle of basic law is that when you have ambiguity in legislation, legislative intent is to be determined to gain what the outcome would be. And if anyone really thought that the Congress was trying to legislate a penalty on people who didn't go for the state exchanges, that's just not real. So I will be very surprised and unimpressed if the court does set this out. But it's going to be a problem. Normally, you'd say if there was a deficiency in the law, the Congress could fix the law. The Congress can't seem to fix anything nowadays, so it's a real serious problem. I don't think there's going to be a whole lot of options. If the Congress throws this out, there'll be substantial numbers of people who will not be entitled to the assistance that they're entitled to under the law now to assist with the cost of health insurance. And if that happens, there'll be sort of chaos for a while. And then hopefully out of that chaos will come some opportunity to do something to remediate and make the state exchanges comparable to the federal exchanges in terms of reimbursement.
So I think if they win that case, it'll be disastrous for New Jersey. We're probably talking over 200,000 people will lose that subsidy or that tax credit that they have received. Premiums would probably go from an average of $5-some thousand up to over $8,000, which will be unaffordable for most of those people. So, at least from the intent of the Affordable Care Act, that challenge, if it succeeds, it will probably be disastrous for New Jersey.
If you remember, too, the first Supreme Court decision dealt with the individual mandate challenge. And the individual mandate grew out of the experience of many states, including New Jersey. New Jersey, when the Solicitor General was arguing that case, cited New Jersey as an example of a well-intentioned individual market reform that said, insurance companies have to take everybody. There can be limitations on pre-existing conditions. They have to have, robust benefit plans, and the rates can't look at health status. And without a subsidy and in a voluntary market, that system ultimately, New Jersey ran it better than anybody else, but ultimately it was not sustainable. That a mandate and subsidies were an essential part of trying to make an individual market work. Remember, people know their health status when they're buying coverage. And it tends to be, folks with higher risk, older folks that see greater value, and as a result, the claims of those folks can be quite high. You want to encourage younger, healthier folks into that market so that insurance works better to spread risk. If you take away that subsidy, and about 80% of the people, who are buying through the exchange are getting a subsidy. If you take that away, it really, say 200,000 plus people in New Jersey will lose their coverage, and those that remain will see spikes in their premiums, and ultimately they will slowly drop out of that market as well. So I agree it would be catastrophic if that were to prevail.
Great. The next question is going to be addressed to Mr. Lloyd. It's a topic near and dear to my nursing heart. Low health literacy has been linked to poor health outcomes, higher rates of hospitalizations, and less use of preventative services. According to the National Assessment of Adult Literacy, only 12% of adults are proficient in health literacy. What steps has Meridian taken to identify and promote health literacy in their patient population? Okay,
I need my notes for this. I'll try to go through this pretty quickly, but this is definitely a big challenge in healthcare. We think we do a great job in terms of delivering healthcare, but obviously if we have issues with literacy among those seeking our help, it's not going to be as effective in terms of the outcome. So part of what we've done is we've actually educated all of our nurses how to identify and work with patients who may present with low health literacy. And that's just something that all of our nurses are trained in. And we look for various certain demographics and signs of those patients that may be in need of assistance. A statistic I would give you is Meridian's Language Assistance Program. provided over 10,400 hours of medical interpreting, serving 66 languages to patients in 2014. So for that population, that's the kind of initiative we've had. We've also formed community advisory committees with each of our hospitals, and they look at the population. They look at what some of the needs are in their local communities, and we get a lot of input from them. And we work with African American Partners in Health. We work with the Hispanic and Deaf and Hard of Hearing, and we're educating and reaching out to them all the time. One of our community advisory committees held a men's health breakfast at the Second Baptist Church in Asbury Park, and that's just one example of some of the things that we've done to reach out, to provide health education, particularly to African Americans, on the topics of cardiovascular health, stroke, and so forth. We also started a church challenge among various churches and communities in terms of, taking charge of their health, educating them about little things they can do, about preventive medicine, about testing and things like that. We also publish biannually Meridian Health Views, which provides a lot of information. We think it's at a level that perhaps not everybody can understand, but a lot of the population can. And then the final one is we use individuals. You probably know these individuals. Harry Carson. We are in Giants territory, aren't we? Harry is a spokesperson and is phenomenal in what he does. And what he does, he reaches out to our communities throughout Monmouth and Ocean County and really talks to them about stroke and the dangers of concussions. And he is very, very dedicated. And we also have Christy Rampone, soccer gold medalist, help educate our younger generation. So these are some of the things that we do. Does that mean that we're doing enough? The answer is no, because there's still a huge gap here, and I think we have to continue to work on it. But these are some of the things that we do.
Yeah, I agree with John. The gap does continue to be huge, and we, in addition to everything you just heard, we've looked at different ethnic groups to see exactly, how are they accessing health care? Do they even know about it? Is it a language issue that keeps them away from it? And we found pretty significant disparities in their ability to access health care or even know what was out there. So we created 2 programs which actually have been extremely successful. One is a Chinese medical program and then another a Russian medical program. And we recruited doctors who spoke Chinese and doctors who also spoke Russian. And it was pretty amazing how it was like people were just coming out of the woodwork, once you established those programs. And we were able to put them through a normal process of screening for certain diseases and their continuing care too. So it is a challenge. It continues to be a challenge all the time.
Just one other thing I want to add. I forgot, very important. We also have a vice president who reports directly to me on cultural diversity. That's his full-time job. And I'm proud to say we are probably one of the few organizations, healthcare and non-healthcare organizations in the country that has committed that resource. Wayne Boatwright, if you run into him.
This points out again the connectedness between the components that we talked about before: access, quality, and cost. Preventive medicine is a very, very good way of accelerating quality, but it also contains costs as well. Chronic diseases represent 70 cents of every dollar. Asthma, diabetes, things of that sort. All of those things are preventable or manageable if, in fact, people know what they're doing. So involvement of the community and information out to the community is a very important thing to ensure quality, but it also ensures access to cost effectiveness.
I would just add that health plans are doing a lot of the same things that hospitals are doing. They have toolkits, they have grants that they're giving. One of the things that I think is interesting around literacy is the notion that peer-to-peer, you talk about sort of bringing in, language and cultural competency into this dialogue. Also, there's a lot of innovative programs that are going on by provider groups. I'm thinking of one that I've just learned about, centering, where pregnant women are brought in together. They're in the same gestational period, roughly, to talk about their experiences with their peer group, with some instruction provided, and that the notion that you're going to learn from your peers in a structured environment in a way that you can more easily learn than trying to pick up a document that best a hospital or doctor or a health plan, is going to be challenged in writing documents that folks can necessarily read or want to read. Those peer-to-peer kind of communications, I think, are going to be really of growing importance, and they're showing a lot of promise.
Great. So I'd like to change gears a little bit, and this is questions for Dr. Vozos. So much of the discussion of the Affordable Care Act focuses mainly on costs, quality of care, and ideological disagreements. However, little attention has been given to the administrative side of healthcare. I was wondering if you could just discuss some of the hurdles or benefits you foresee from the Affordable Care Act from an organizational perspective, and then just have you seen any dramatic changes since implementation?
Well, I'd say we started off with hurdles. What's going on in healthcare today, with or without the Affordable Care Act, is that it's changing pretty rapidly from an inpatient enterprise to an outpatient enterprise. Every year, what used to be performed on the inpatient side is not performed on the outpatient side. Statewide, I think we're seeing close to at least a 4% drop in inpatient admissions across the state. And in some cases, you're seeing even a slight drop in the outpatient services, too. There's a category of patient care called observation. These are patients that come in, they don't stay, they're not truly admitted to the hospital. And if you can be efficient, they're in and out of the hospital, hopefully in less than 15 hours or so. What we're seeing nowadays is that many of the patients that used to be admissions are now observation cases too. So it requires, to do that effectively, you need to be much more efficient and be able to perform all this testing within a short period of time. That is a change of the way hospitals have operated. We are expected to deliver the same high quality care with a lot more reduced subsidy or payment too. So, we looked at, one of the hurdles that the Affordable Care Act put on us right at the get-go. I mean, I think everybody will appreciate that as the Affordable Care Act came into play, there was all an agreement by the hospitals across the country to contribute in however, you can use whatever word you want to use. If we will contribute, they'll take it away from us. But
They took it away, Frank.
About $150 billion to make this go. So in a way, we front-loaded the Affordable Care Act in the expectation that there was going to be a lot more patients with Medicaid and also a better reimbursement. As that moves along, there are different subsidies that have been taken away. So I can just tell you for Monmouth Medical Center alone, in 2015, there was about $4.2 million worth of subsidy or reimbursement that's going to come out of us. And it'll come out in the form of either, and that's not including the charity care reduction that's occurred at the state level. So that all has to be made up now with this increased Medicaid. And we all know that, I think we all know that Medicaid really covers about 70% of your costs in the hospital. So you always have that 30% of uncompensated care that's going on there. So it's a very tricky economic game right now. So it's kind of put everybody on the fast track of really, figuring out rapid ways to reduce costs and the cost of your care, but at the same time maintaining at the highest quality that you can. So that's a tough game right now for most hospitals across the country. I think we're all working very hard at it, but to make that really work, it's going to take a lot more work. So from an administrative perspective or even organizational perspective, it's changed the way we play the game a lot. You're seeing changes occur in almost every sector of healthcare. Today, more than ever, more physicians want to be employed by the hospital because it's a very uncertain world out there. If you want to go out into private practice, those old-fashioned, much-loved single doctor or two-doctor practices, they can't survive anymore in this environment. So that, the whole game is changing right now, and I think it's going to rapidly keep changing at least over the next 4 or 5 years to where we're really going to be. I don't think 5 years from now it's going to look anything like the healthcare that we're doing today.
I would say that just to add, I'd agree with all those comments that the, intended or not intended byproduct of the Affordable Care Act is that it's very difficult to be small, whether it's a hospital, a doctor's office, a health plan, nursing. I mean, just, it's really the compliance costs, we're being driven together into sort of bigger, sort of units. The health plans are probably, going to be consolidating a little bit. Certainly the hospital community has doctor's offices being purchased. The landscape is dramatically changing. It's, we as in New Jersey, even before the Affordable Care Act, really had a higher prevalence than most states of small doctor's offices, 1 and 2 person shops. Again, that's really, it's difficult to survive in this climate, and all that's being asked of you to do that. I guess the other administrative sort of thing I'd say is that there was so much to do with the Affordable Care Act in a short period of time, and as a former regulator, I have enormous sympathy for the folks sitting in Washington writing the regs for all the things for the hospitals, the health plans, the insurers, and everyone in healthcare. An enormous undertaking in a very short amount of time. From the regulated community, you want clarity. And you want things that make sense. We really did see some changes where, you build your model around what you were told, and then, the federal government really did make a lot of last-minute changes that, I think in many respects, some of it was the result of the failure of the healthcare.gov and the rollout of that. They had to do a lot of sort of cleanup, but it was a very bumpy ride for a lot of entities in healthcare. And hopefully we've passed that difficult startup phase.
Another one of the, I'd say, hurdles that we have to get over is really the electronic medical record. Though that's a must, a necessity in healthcare, there's not even a common platform that everybody, uses. So even transmitting or sharing information with all the different entities that perform healthcare is still difficult. Yet there are already penalties being put in place, for certain, whether it be meaningful use along the way. That so it's very, very tough, let alone very, very expensive to put those programs together.
There's 2 items I want to respond to. First, there's a need to be cautious about the consolidations that are taking place. We obviously want to have collaboration as much as possible, cooperation as much as possible. But now with hospitals merging, with insurance companies merging, in addition to horizontal integration, we're having hospitals acquire insurance companies acquire hospitals. And in the marketplace system, you can reach diminishing returns at some point, where you don't have competitive forces, which have really been relied upon in this whole initiative to contain costs. And the other point with regard to technology, every business in operation that has a need for capital usually pays for the capital by trade-offs on employees. Healthcare is unique. Healthcare is unique in the sense it's labor intensive. There's just so many things you can do, and yet it still has to have capital intensive. So what you have is more jobs being promised. You go to local mayors, particularly in the cities, they'll talk about the hope being eds and meds, education and medical. That's the job opportunities. So rather than most businesses which trade off capital for technology with employees, healthcare is expanding employees, and they're expanding the capital needs for technology. So that's a potential dilemma as well.
This next question is for Mr. Sanders. Before a health insurance plan pays for healthcare services, the patient is responsible to meet an out-of-pocket maximum limit. The maximum out-of-pocket expense for an individual plan in 2015 is no more than $6,600 per individual and $13,200 per family. Individuals and families covered under the healthcare marketplace may now be insured. However, deductibles and out-of-pocket expenses are high. How will these impact enrollees from seeking services knowing that they have to lay out huge expenses before the insurance plan will begin to reimburse?
Good question. So if you look at a pie chart of New Jersey, so we have almost 9 million people in New Jersey. There'd be a lot of slivers of that pie representing where folks get their health insurance coverage. They may get it through Medicaid, state-federal partnership. generally for lower income folks and for some disabled folks. They may buy it in the individual market on their own. They may get it through their employer, who may be a small employer or a large employer, different rules. They may be with a larger employer who self-fund their benefits. They retain the risk. They may hire an insurance company, but it's really the employer or the union that bears the risk of that. It could be Medicare. It could be the state health benefits program for state and local employees. That covers almost 10% of New Jersey residents. So there's lots of different elements of where folks get their coverage, and the cost sharing that they face tends to differ depending on where they get their coverage. So in Medicaid, in recognition of the fact that these tends to be lower income folks, there's very little or no cost sharing for consumers. In the individual market, when folks buy it on their own, one element that's not really talked about too much in the Affordable Care Act is that not only do you get a premium subsidy to buy coverage if you're within below 400% of the federal poverty limit, you also get a cost-sharing subsidy up to 250% of the federal poverty limit. So you can buy a plan, and then the federal government will also help with the cost-sharing components of your plan. So it's really a much richer plan than it appears on its face in some respects. Small employers, large employers, and unions, it really is at the discretion of the employer what they select. The out-of-pockets that you discussed, I think, are really relate to the individual and small group markets for the most part. But you're right, there can be significant exposure to cost-sharing elements. The one exception I would add is the Affordable Care Act for all size groups, including Medicare now, has preventative services at no cost sharing. So that's first dollar coverage for preventative wellness kind of visits, so your colonoscopy and things like that. But you do have to face that. The notion of a deductible and copay, all those cost sharing features play two roles. You could say one is that they want to have the consumer have some skin in the game so that they can think about the cost. If they're totally insulated from that, purchasing something for $1,000 or $10,000 becomes meaningless if they don't have much in play in terms of their cost-sharing component. So it's intended to make people as a better shopper for health care coverage. It's also a necessary lever for the cost of that coverage. If you have low cost-sharing, the premium is very high. So those plans are offered. It's just that they're rarely selected if they have really low cost sharing. So and it's also intended to avoid inappropriate utilization of care. So if somebody has the sniffles, do you go to the doctor on day one, or do you just sort of wait that out a little bit? But there's no question that it does have an impact, and it impedes access to appropriate care in some cases. And that's a challenge. It goes back to my initial point, which is we've solved a lot of things. We truly haven't gotten over the hump on affordability that addresses everyone's concerns. So it's a remaining challenge.
And I'm a little concerned about some of the trends. I mean, our system is essentially an employment-based system. I mean, most people get their health insurance through their employment, which of course means that we put the cost of that insurance in the cost of the product or in the cost of the service that's being provided. We're the only industrialized nation in the world that finances that way. That means our business people are at a competitive disadvantage when they go into the market. At one point, the automobile industry, 10% of the cost of a car represented the cost of insurance for the employees and retirees. The business community, inevitably and justifiably from their standpoint, are going to look to offload those costs. They're going to offload them on the government if they can, or they'll offload them on copays and deductibles. So we have to be a little aware of that, because if it goes too far, we'll be uncompetitive again from a different standpoint.
Great. So we'll return to Governor Florio. I specifically want to talk about your term in office as governor. So given your interest in healthcare during your term, ranging from the issue of rising costs of healthcare, as we spoke about before, to the passage of the legislation aimed at mandating low-cost health insurance programs and providing medical services to lower-income portions of the population, what are your thoughts on the goals and accomplishments of the Affordable Care Act since implementation, and what do you see for the long term? Do you see it as in line with what your goals were as governor?
I think the things we did were early on. Many of the things in the Accountable Care Organization, Affordable Care Organization, were things that we did with with the cooperation of a whole lot of good staff people. Some people in the audience may know Amy Mansue, who was the head of the Children's Hospital, was one of my staff people and a very, very good person. But there was much more to do. We could have done more. We tried to have a healthcare plan for the state so that everyone was not tripping all over each other, and there'd be a rational allocation of resources around the state. Everybody doesn't have to duplicate what everybody else said. When I was growing up in Camden, and I became involved a little bit in government, we had a situation where we had 3 hospitals. At that point, it was Cooper Hospital, Lady of Lords, and West Jersey. And one had one specialty in heart things, another with kidney problems. And all of them at that point, and this is like 30, 40 years ago, all of them at that point wanted to duplicate what the other hospital did. And we wanted to have a plan so that you would allocate and use through the certificate of need process responsibilities to allocate resources in a sensible way as opposed to competing with each other. So the things that we did early on that we're not catching up with, but the problems are still the same. Say access, quality, and affordability were problems then, and there's still problems now. We're starting to move more progressively, I think, in an area to deal with those things. One of the things that's already shown some success is the whole idea of trying to induce hospitals not to have readmissions. That is to take care of people so that they're not readmitted. And that's being done, I guess, with the stick rather with the carrot, saying if you don't take care of this problem of premature people going back into the hospital for readmission, there'll be a penalty. And my understanding is it's already demonstrated sufficient monies yielded to make it a success for a successful approach.
The next question is for Mr. Lloyd. How have the distribution of costs changed since implementation of the Accountable Care Act? Meaning prior to the ACA, care was never denied to the uninsured, resulting in numerous defaulted payments. However, with increased access to health care, will you see a shift in this trend? If so, is the burden merely shifted to insurance companies, or has the policy accomplished the goal, decreasing costs while increasing access?
That's a really hard question to answer. I think the fundamental issue is if now we have more patients covered and we're being reimbursed, is there some lowering of cross-subsidization by the insurance companies? Before I answer that, I'm going to just show you this is the Wild West, and Frank was talking about this. So here's what has happened at Meridian, and I'll give you the pluses and the minuses, and if you can follow it, and if at the end you can figure out whether we're better off or not, God bless you all. We talked about in 2011 that many what used to be overnight admissions were classified as observation cases, and that was done across the entire country, and that cost Meridian $30 million in lost reimbursement. That was in late 2011. We fast forward to January 2013, and now, a little known fact, the Accountable Care Act, they estimated about $1.2 trillion was the cost, and they decided they would get $600 billion from the hospitals and physicians. So we coughed up another 30 million. So you're with me, right? I'm down 60 million. Okay. Now we say some good things are happening. People now are being covered. And we were very, very aggressive in terms of helping those that were uninsured get enrolled for Medicaid. In fact, in a little over a year, we helped about 2,600 individuals who did not have coverage get enrolled in Medicaid, and many of those found their way into the managed HMO, managed Medicaid products. That meant, for us last year, that meant we got $30 million more. It's just coincidental, they're all by 30 million. You know, can't be 5 or 10, it's 30. So the answer is, it's yet to be determined. You know, we still have a very fragmented system when it comes to reimbursement. So you just saw those swings in reimbursement. Now you saw a positive with more Medicaid covered. Other things that are happening, the penalties that were talked about, within a year or two, we could be at risk for 8% of our Medicare reimbursement, which is a lot of money, if we don't meet certain quality and readmission things like that. The other thing is we're still dealing with a lot of uninsured. You know, if you look at our governmental reimbursement between Medicaid and Medicare, we're still out about $115 million. When you look at bad debt, we're out probably another $75 million. So right now, particularly in most of our organizations, you have so many pluses and minuses. It is a very, very tough environment to manage through. So I don't think yet we can avoid cost shifting. Perhaps there's going to be some decrease in some of that cost shifting as things sort out. But right now, these are huge swings in our organization that we have to deal with.
Yeah, exactly as John said. I mean, when we look, you know, there's really good-looking news when you do the first glance at what's going on. Like, for example, in our emergency rooms, or at our emergency room, the inpatient component of our emergency room from Medicaid actually went up 23%. That was about 488 admissions. Okay. The treat and release, you know, the people that are just coming by the emergency room, get treated, go home, that went up 75% for Medicaid. And we saw pretty much a concomitant decrease in charity care. Like inpatient admissions went down about 52%, and the treat and release went down about 31%. So, and what you see, and there's studies on it now, people that have a Medicaid card, they tend to utilize the resources much more than, let's say, the average citizen out there. I'm not sure, you know, I'm not sure they've figured out why. Some of it's very good. You know, they will go to the primary care more often if they can find one. They'll do the screenings more often if they're brought to them, and they will also be the highest users of your emergency room too, because they lack, you know, most of the time they lack a primary care physician, and that's a problem that sort of gets overlooked all the time. That it's great to have all these people insured now with Medicaid, but find the doctors who accept Medicaid. There are just very, very few of them out there. And until that reimbursement structure changes, I don't know that it'll ever kind of succeed to the level it needs to succeed, because yes, we can hire doctors at the hospital, in which we've done, that do take Medicaid, but the private practitioners out there do not take it. So the access to care for the moment continues to be the emergency room many times, or the employed physicians at the hospital. On the other hand, the people that went out and bought their insurance, I think the statistics were that over 32% purchased the highest deductible type of plan. So, and we're seeing that. Our bad debt at the hospital has gone up about 32%. And that's because of those high deductibles that people just aren't able to, you know, they are not able to pay it. So there's still, as John said, a lot of tweaking that has to go on before we have this down pat, you know.
This is very complicated, as was stated. There's a wonderful book that you might want to read that I think clarifies an awful lot. It's called America's Bitter Pill by Steve Brill, B-R-I-L-L. It really makes readable and understandable some of these points.
I would just add, when I imagine the C-suite folks at the hospitals in these challenging years, I imagine white-knuckled and grabbing on to just anything that they can. Because as they've said, you know, a lot of it sort of depends on their payment streams, and it's wildly shifting. I just got the Medicaid enrollment numbers today before I came here. New Jersey's now over 1.7 million people out of 9 million. I don't know what the percentage is, like 18, 19%. So almost 1 in 5 New Jerseyans now has Medicaid. You know, if you look as a hospital, you know, if that's coming, you know, while that pays, you know, they say 70 cents or whatever for the dollar of care provided, if previously you were getting less than that because it was somebody who was a charity care patient or somebody else for which there was no payment, that represents a, you know, a net gain. In the individual market, it's probably up over 200,000 lives. And again, but the reimbursement for Medicaid, Medicare, the commercial plans, all different. So the payer mix really sort of, you know, sort of dictates wildly what happens. And then the state is trying to look at this with a very tight budget. You know, it's about a $33 billion budget. In the past years, charity care has been, I think last year was $650 million. They're knocking it back down to 500 on the basis of presumed savings because of Medicaid enrollment and other expansions. I would make one comment I would just disagree a little bit with, was the notion, you know, the Medicaid plans Most folks in Medicaid have a connection to a primary care doc, and even ones that are showing up in the emergency room, they'll have claims for primary care docs during the year. Primary care docs have not been a significant challenge in Medicaid for the most part. Subspecialties, especially around children's, pediatric specialties, subspecialties, are challenging in Medicaid and in other areas. But you still see people with Medicaid cards showing up in the emergency room, and that's a cultural shift. I think that some of that is convenience. If the hospital is open 24 hours, has a nice warm emergency room, and your doctor has certain hours, it could be that it's easier just to go to the emergency room. So the plans are trying to steer those folks into the primary care docs that they do have a connection with, but that shift is complicated to make sure that folks are receiving care. It's much, I think everyone agrees, it's better to get the appropriate care at the primary care doc if it's not necessary to be in the emergency room. So they do have a connection to a primary care doc. It's just they're not always using them when it's in some ways a matter of convenience.
Dr. Vozos, we've heard a lot about sort of opponents of Obamacare have really sort of hammered on the jobs, right? That it would really have a detrimental effect on jobs. So I was wondering if you could just talk about if it had any effect, especially coming from a large medical organization such as Monmouth Medical, if there is any effect on the administrative or health professional hiring since implementation.
Well, you're right, this is sort of the double-edged sword. I mean, on the one hand, you want to sort of reduce costs because that's part of how you're going to have to survive. On the other hand, the Affordable Care Act, and actually the way healthcare is going, has sort of created some new areas of expertise that every hospital needs. You know, very much is going to be based on outcomes now. So the ability to track that and create programs and monitor all that almost requires a new type of professional than was typically seen in the hospitals. You know, now you see it's not so new, but that CMIO, that Chief Medical Information Officer, or the medical informatics people are increasingly, almost essential now to manage a hospital. You need that type of information. So it's opened that avenue for hiring. On the other hand, on the other side of that, as we hire somebody in that position, then we're looking to see how much can we consolidate over here to sort of cover that, keep it as much as we can budget neutral. So I would say that, over the last several years, most hospitals have tried to get as efficient as they possibly could, whether it be in terms of staffing or how different programs are run. So I don't know that there's a lot of fat left in that in that area for any more.
Yeah, I would agree.
Saving, right?
I think all of us have taken, huge initiatives over the last few years. We have a 3-year initiative to remove about $100 million. And, it's sort of interesting because most of us want to make sure that we don't jeopardize patient care. So the patient care areas we usually don't touch, but volumes are down, so we're not filling some of those positions, so we see some savings there. And in our organization, we've seen a huge shift because we have, recently I presented sort of the state of Meridian to team members and leaders, and I showed them a PowerPoint. It had like 5 divisions on it, and the hospital was only one of the 5. So we are hiring in many of our other divisions. We have population health. We probably have 20 people now. We'll probably be up to 30 people by the end of the year. We're very aggressive in the ambulatory care area. We have 100 ambulatory care facilities. So in all those areas where we're expanding, we're hiring. And in the areas that matter, where we can make the hospitals more efficient and where we can make them part of the continuum of care, we're also doing that. So, we are trying to in the non-patient care areas, trying to reduce some of the traditional hospital positions, and people are moving into some of our newer areas because under population health, we're going to benefit from a very good structure. We have 20 now. We'll probably be up to 30, probably be higher than that. So we're putting our money into the future.
So then would you say it's a bit misstated to talk about the issue as as less as job increases or decreases, and more so shifting of the
Our experience, and it sort of varies. You know, if you're a financially stable organization, and we are, we're able to invest in some of these other areas. Some of the hospitals, particularly the standalone hospitals, really pretty much are cutting, and they're not investing in anything else. So, you know, in New Jersey, it's really interesting. There used to be few health systems, and now out of, I think, I keep track of this, there are about 72 hospitals in New Jersey, and all but 18 are in health systems now. So you can't, someone made the point before, you know, if you're a standalone single hospital, it's pretty hard for you to have the critical mass to be successful. But I'd say the stronger organizations are simply reinvesting in the future, whether it's population health, you know, whether it's, you know, new and innovative things that, you know, we've done a whole bunch of things. That's where we're investing our monies.
I would note for the health plan community, I've never asked the plans to do a belly button count to see whether they have more or less folks there. I would say that the consulting community probably has done very well as hospitals, health plans, doctors, ACOs. Everyone needs expertise quickly that you don't necessarily have in-house. So I think a lot of the consulting shops, you know, this is the best thing since Y2K.
Okay. Mr. Sanders, a leading health indicator in Healthy People 2020 is clinical preventive services. Clinical preventive services offer longer quality of life, better health outcomes, high quality care, and reduce long-term health costs. How do we address a healthcare system that continues to focus reimbursement more on disease treatment rather than disease prevention?
Well, it's a good question. On the prevention side, I would note, I mentioned this earlier, that one of the nice things in the Affordable Care Act is that it does encourage folks to receive care, preventive care, and receive testing. So it's a little complicated, but there's entities in DC that are evaluating and grading certain things, you know, whether, you know, when you get mammography, when you get a colonoscopy, and so forth. And if it's graded, I think, A or B, through those grading agencies, it's first dollar coverage. So there is encouragement in the healthcare system to make sure you get those screenings. I think the studies have shown that while that improves health outcomes, I don't know there's necessarily been a proof that it's actually saved money, but it does have a benefit in improving health. On the larger question, though, I think that you're seeing, as Governor Florio said, you know, whatever, a fifth of the U.S. economy, close to a fifth of the U.S. economy is healthcare. So to change that on a fee-for-service, pay-for-each-service kind of basis, move it away from treating illness to treating, to trying to keep people well, that enterprise is underway, but it's like moving a ship in its direction. So it's going to take some time, but I think it has in principle, it has the backing of health plans, it has the backing of hospitals and doctors and so forth. Folks, you know, are afraid of what the change in reimbursement can always mean that there's winners and losers. So it is a scary process. So a lot of it's pilot programs, moving slowly, but I think there is general consensus that this is where we need to move. We need to move to wellness. We need to move the payment structure away from a fee, you know, pay for every service to trying to pay to keep people well. And that there's a lot of hope that, you know, this is one of the elements of the Affordable Care Act that shows promise in trying to hold down costs. And it started in some ways before the Affordable Care Act as well, but I think the Affordable Care Act has pushed it along.
There were two initiatives that are very interesting and are running into some difficulty with some of the interests. One is designed to look at protocols, look at what works or what doesn't work, evaluate the efficacy of some pharmaceuticals versus other pharmaceuticals, all designed to make recommendations. And then there's another one that looks at Medicare, has the authority to actually make some modifications for cost-effective changes in the Medicare program. But these are both put in the bill, but so far the different organized efforts that are, or organized interests rather, that are not looking forward to change have been stymieing that.
I mean, to that point, it's a conundrum that we always have, is that one person's cost is another person's expense. And that's the conundrum of trying to change some of these things, to try to attack some of the cost it does run into, you know, it's someone's income stream as well. So it's always challenging.
All right, well, I think we're going to move now to some audience questions, and not a better place to start than from one of my former students. I don't know where he is, Stephen Lang. He has a question about youth people, right? Younger people trying to gain access to healthcare for the first time.
How do you feel that the Affordable Health Care Act affects youth, many of whom have never had to search for health care through any markets, whether it's been provided through university plans or parental plans? Many do not know how to search for health care and are now being launched into this turmoilous system.
I'll take a crack at that. There's a couple elements in the Affordable Care Act that really impact folks. One is that across the country, there's a requirement that coverage include dependents up until age 26. So previously, under most health insurance plans, you're covered under 18 unless you're in college, then until your graduation, unless you were on the 7-year plan there. But you would lose coverage when you would graduate. So when you know, the dean handed you the diploma and you walked on the other side of the stairs, and all of a sudden you could be uninsured. You know, a really nice component, it polls well, as we were talking about polling, is to mandate coverage up to 26. It does have a cost. You know, some employers, you know, I have essentially a small employer plan, and you know, if you're contributing toward dependent coverage, you know, and those kids normally would have aged out, it's still a contribution for the employer. But it seems to have been well accepted. I think the other is the subsidies that are available. When you're just starting out, you tend to have lower income, so Medicaid and the Affordable Care Act, if you're not eligible for Medicaid, does offer some subsidies. But you're right, and it does get back to this literacy issue is, you know, it's like the first time you're buying anything that's complicated, and this is really complicated. There's a challenge. So I think in addition to health literacy, you know, part of this, the challenge we have as a community is health insurance literacy too. You know, what is a copay? What is a deductible? When it's coming out of your pocket as a young adult, now it matters a lot. So I think we have a ways to go in trying to educate folks as to what it is that they have. What it is they have.
Yeah, my question was, getting chemotherapy, radiation therapy, will they be affected severely with the Affordable Care Act? I know with Medicare, I know some of the tests, they seem to question whether they're going to need as many tests for someone with cancer. And I was just wondering what you thought about that with the Affordable Care Act.
I'm going to say that that's not what's going to affect it. It's going to be, what will affect it is the emergence or development of freestanding, let's say, for-profit centers that either perform radiation therapy or even infusion centers that will sort of undercut or price themselves lower than, let's say, what a typical hospital is. You know, unfortunately today, most hospital-based services tend to be a little more expensive than some of the freestanding services out there. You could argue about where you're getting the best quality, but that doesn't necessarily rule the day. At the end, it's where where an insurer may steer you, or your copay. It may be what your copay is, because some insurance companies will, you'll be a preferred provider there with a much lower copay. In fact, they're pretty bold in telling you when you call up that, well, yeah, you can go to Monmouth, but you're going to have a higher copay. They'll actually tell you that on the phone. So, I don't know. That's what I think could be happening. I doubt the Affordable Care Act would have any impact on those types of services.
If I could just add to that, I think most of us have seen the stories about the escalating cost of chemotherapy drugs. And I can tell you, we've never, ever seen the price increases within our hospitals that we're seeing now. And it's out of control. And I think that, that's something that we should all worry about. And I'm not picking on the pharma companies, but the drugs are just out of reach for almost everyone now.
I would echo that, whether it's, the state health benefits program and Treasury's paying for it, or a union's paying for it, or an insurer or an employer, the cost of some of these drugs, and some of them are just great drugs, but the pricing structure on some of these things has just gone through the roof. There's a new Hep C drug that's been out for a little over a year. Course of treatment can cost, $80,000. If you needed a second cycle, it's like $140,000. Great drug, treats most Hep C patients and cures them. It's a great drug. But the pricing on it is really astronomical. I do agree that this is, one of the challenges that folks with, especially cancer or immune diseases, where those drugs tend to be located, that's going to put pressure on access to care.
But even like generic drugs, I just have to see the paper now, the generic drugs where they were $10 before, now all of a sudden they're $90 for the same thing. That doesn't make sense.
But the Affordable Care Act is supposed to be spreading risk. Now, one of the key things there was the spreading of risk. So risk may not be just to the insurer right now. It's going to be out. It's the provider, the hospital, but also the pharmaceutical companies, because the ability now to sort of get into the retail side of the market and be looking at pricing when you're buying pharmaceuticals should have an effect at some point on the pricing of drugs too.
The difficulties were that there was no change in the law that disallows the right of Medicare to negotiate for prices with the pharmaceutical companies. That's still preserved. And there's no ability to import, even from Canada. I'm not talking about third world nations. There's no ability to import, which is, again, a limitation on what the marketplace would do.
As a healthcare provider, we all talk about our vulnerable populations. According to the CDC, social inequality is often associated with poor health status. Compared to their heterosexual peers, individuals of the lesbian, gay, bisexual, and transgender community are at increased risk for health threats. What initiatives have been undertaken at Monmouth Medical to address these outcomes excuse me, in the LGBT population? And what have been the results of these initiatives?
Well, I will say this, that that sector of the population has the same access to the health care that everybody else does, so there's no discrimination in that regard. We do have physicians that do take care of that community, both from a surgical perspective and other areas, and also our behavioral health unit provides a considerable number of support groups for those who seek those support groups. We also have a pretty substantial AIDS clinic that is available to anybody who's stricken with that problem. So I guess our services used? Yes, they are used considerably, but I'm not sure what more than that I could give you.
Can I just add something there too? Is that the beginning part of your question was, I think, important, and that is that there's a growing recognition that the social determinants of health, whether it's adequate housing, education, do you live in a food desert where there's no access to care, that those kinds of questions, I think that there's folks are starting to look at that in a keener light. It doesn't make sense to spend $200,000 on a patient with asthma who ends up at 7 different emergency rooms and is there 50 times a year because they have mold in their house. So I think that there's a look now. There's a lot of healthcare advocates. We've been talking to the housing folks, to take a look at those social determinants of health, and how we as a society are paying for things, because in many ways we're paying for it poorly. So to take a look at housing issues, our Medicaid plans, go into the home, and you learn a lot as a nurse from a health plan goes in and says, "Oh my goodness, no wonder you're showing up at the emergency room because of the conditions in the house." Trying to connect them to food stamps and so forth. So I think it's the beginning of your question was a really good, important point that needs to be made, that we need to make a lot more progress in that regard too.
I think accountable care organizations are particularly good vehicles for taking into consideration those types of things.
We have a question from Sherry Eckstein.
Yes, I'm a health broker, health insurance broker in New Jersey, and my question is, in New Jersey, it's really affected the small businesses that are mom and pop shops, partnerships, and those who want to provide health care to their independent contractors. They're no longer able to do this. And those people are forced either into the marketplace, into individual health insurance that they may not be able to afford. Is there any provisions or any ideas of what might be done to correct that in the future?
Yeah, this is, for some folks may not be aware of this, but the definitional, this is the complicated intersection of federal and state law. So the preemption provisions of the federal law, unlike some federal statutes, don't say, well, the federal rules apply. It's a complicated analysis as to whether the state law prevents the application of the state law, and sometimes it's very hard to do that. But one of the areas where there was a change was the mom and pop shops traditionally had been buying in the small group market, as you noted, where there was probably a broader range of choices, and they've been forced because of definitional components in the law to now buy in the individual market. The individual market is receiving a temporary subsidy, so I think that 3-year cycle is up next year, so I would expect prices to be impacted. So the plight of the mom and pop shops should not, there's winners and losers in this, and depending, what market you're in and where you end up. But clearly, it's been a very bumpy ride for those mom and pop shops. And to your question, I don't know of any, as Governor Florio said, a legislative fix is probably not likely from Washington on that.
And the second part of that is that they no longer get to write off their premiums as a tax benefit. That's kind of a double whammy for them.
As I say, it's been a bumpy, yeah. It's one of those areas, there's lots of folks that you could point to. The proponents of the law would say this has been a great law. There's definitely folks that have been adversely impacted as well, and that's a great example of folks who have.
And I suspect as we go forward and the national debate takes place about overall tax reform, the ability to write off things, particularly in the health insurance, is not going to be increased. I suspect it will be decreased at some point.
A couple quick questions. You said that the cost of health care is about 18% of GDP. I'm curious how we got here, and maybe debate the answer to say what were the physicians and the hospital's roles in getting there. What's a more realistic number, and how do we get to that number?
Well, how we get to that number is doing, hopefully, the things we all talked about here all day, bringing down the cost. How we got there was just lack of appreciation of the escalating costs through an employment-based system. Now what you're seeing is people, as I said earlier, trying to offload so as to bring down. The question is, are you really doing a whole lot of great things if we're reducing costs to the government by handing off costs to people with co-pays and deductibles, or if we're just shifting from the employment to the taxpayer? There's a need for modifications across the board to shoot for better quality at a more affordable cost, and that's not going to be easy. It's very complicated. Other people around the world have been able to do it. They provide better infant mortalities in this country equal to third world nations. So we're spending a lot of money. We're getting access that's not there. We still have about 30 million people without health insurance. Commendably, the ACA brought in 14 million people so far in terms of coverage, but we still have a lot of people left out.
So
I have a comment too, by the way, just that if you were to design a healthcare system, you never would design this one. That's true. That we ended up here is, as the governor noted, in some ways a matter of happenstance. In World War II, there was wage and price controls, and there was a shortage of labor because there were so many folks fighting in the war. That businesses did have the ability to provide benefits through life and health insurance, and so that's how they tried to entice people, and that was really what generated our employer-based model. It wasn't really by design; it was by a accidental consequence. But here we are. But I do agree with the comments that were that the real cure for this is not the cost shifting, and that's going to take place. But we really need to leverage technology in a better way than this industry has. You need to align payment in a more a better fashion so the care is delivered and paid for in a way that makes sense, where hospitals, doctors, and the payers are sort of have a better alignment in trying to control costs.
I mean, one of the key points of the ACA is to get off of the mode of dealing with things in a cost assignment, not a fee for service. As of now, what we do is the more people run up, the more they get paid. So we have to have some inducements to have people look for more cost-effective solutions.
So we have a question from Dr. Janowis' class about the single-payer system. Any volunteers? Is Dr. Patton still in the house? He still has a question about that.
It was that question too. Yeah, thanks for being here. So, should we have enacted a Canadian-style single-payer system rather than the mandate? And why or why not? What would have been the pros and cons from your perspective?
Obviously, there are people that don't want to do that sort of thing. I suspect there'll be another bite at the apple in 5 or 10 years where we'll do a system where we have public options, or we'll have a system of single payer, or Medicare for all. I don't think we're done with this. I think over the next number of years, we'll look at what we have to do, because I don't think we're going to really be able to contain costs that much, because there are just so many things that are beyond, I said, monopolization. As there's more centralization, that's a problem. That's not responsible. That's not the responsibility of the Affordable Care Act. But I think there's just an inevitable absence of the ability to contain costs to a much greater degree. That could contain somewhat, but I suspect we'll go back and again in a couple of years, look at this whole thing and modify it to result in less administrative costs. I mean, it's an interesting thing to look at. The administrative cost of Medicare is like 2 or 3%. Administrative cost of private sector provision of care is 10, 12%. I think that's going to be a problem we have to deal with.
I would throw in that, to try to change from our current system to shift to a single payer system, I mean, it's been a bumpy, difficult ride to change the system as we've done now. To try to change our model to a single payer system would have been a lot more complicated. So it would have been a much tougher lift. One state, Vermont, has tried to do it. I think that their efforts have ultimately, it collapsed under its own weight. They were talking about a tax that was enormous that I don't think they could have borne. I guess the other thing is that the advantage of a public option or a single payer option is that government sets rates. Insurance companies and hospitals and providers negotiate rates. When you have Medicaid and Medicare rates that are less than the value of the services provided, I think there's been a traditional distrust of the provider community around where those rates are set. Can they be reasonable? So, again, it's not something that obviously the health plan community would have supported. If you do move to a payment model where everyone is all in, there are various ways to do it throughout the world. You see, in some ways, the government provides care, or in some cases, it's like Medicare Advantage, or the state Medicaid programs. State Medicaid programs have moved mostly from state-run programs to managed Medicaid programs through vendors.
The other thing I would just add, I really don't think the American public would accept a Canadian system. And I say that because as a provider and being in this field for a long time, the American public expects service now. They don't want to wait for an MRI. They don't want to wait for surgery. And in Canada, that's some of the criticism you hear. So I think even if we all thought it was a good idea, it's not going to happen. I just don't think the culture here would accept it.
I wonder, though, if that's sort of a part of a natural progression. I mean, we saw the status quo of healthcare shift, right? I mean, we think back to the Clinton administration, right? The individual mandate came out as the conservative answer to the reforms suggested by the Clinton administration. So do we see this sort of as a stepwise way towards something more of, right? Even during the debate over the Affordable Care Act, there was the debate over the government option, right? So, I mean, do we see something more of a stepwise progression that we could see universal, maybe not a single payer system, but at least towards a universal coverage?
To me, the step of the Affordable Care Act, which was noble and necessary, was the notion that, we had this system where you had Medicaid eligibility, which was really for pregnant mothers and kids and some disabled folks. You had employer-based coverage. You had tiny individual markets that were dysfunctional everywhere across the country. And then you had this piece in the middle where folks were not income eligible for Medicaid, but there's no way they could afford coverage. There's been a commitment from government. It was hard at the state level to do that, but the federal government stepped up and did provide the funding for those folks to be able to get coverage. It's not all the way there. To me, universal coverage, there's different ways to craft this, but you do need a commitment from government to be able to get folks that can't afford it into a place where they can.
Just one other thing. I think that, I'm not sure if I can say this articulately, but if we don't see substantial improvement in the next 3 to 4 years, I think single payer may be back on the table. I really believe that. So I think it's really up to all of us to try to make this system work. There are some good things that are happening. It was already said, why did the cost escalate so much over all these years? The reason is because the incentive was we were being paid for piecemeal work. And, I don't, leave fraud out of this, but the natural inclination, if you're a clinician, is to treat people, with as much diagnostic workup and as much whatever. And that's, now what you're seeing is now payments are going to be more bundle payments. We're going to be more risk. We're going to have to find ways to move toward population health, more wellness and prevention. So there are a lot of organizations that are moving in that direction. And I think if we can see some progress there, maybe we won't go to a single payer system, but I think it's incumbent on all of us in the next 3 to 4 years to try to make this work. And there are some good signs, and there's some things that have to be fixed. From a provider viewpoint, I can tell you, we're prepared for dramatic changes in our organization. And I think the more progressive organizations, and Frank's one of them, it's not going to be like it was. It's just not. That train left the station a long time ago. And we're all out there looking at new and innovative ways to do it. We're going to be more at risk. We're going to have to do bundled payments, all that stuff, shared savings.
There will be, I agree, a dramatic change for some people. You think about, wasn't even that many years ago when if somebody came in a hospital, they could have come in for, let's say, a hernia, but while they were there, somebody would say, well, while you're here, let me do a chest x-ray, and let me also check how your thyroid is and things like that. Well, all that is denied payment right now, but that just increased the cost. So that's all gone. It should be gone anyhow. Hopefully it's gone out of my place. But anyhow, and what you're going to see going forward is much more standardization of care, across a lot of levels, and also across hospitals. There's plenty of evidence out there now of what is the most effective or efficient and the best care for different disease states. Yet, if you allow it, and every doctor is well-meaning, and they all have maybe their own approach to something, but there's a lot of variability. That variability is expensive in many cases too, and also increases the length of stay in the hospital. So that's all going to go away. We're going to have, call them care maps or clinical pathways that everybody has to follow. Intensive care units really should be, if you want to be totally efficient, should be run by intensivists only. Rather than having every doctor coming up there and, again, doing the best they can, but managing every patient their own way. So there's going to be a very dramatic change, I think, in the way healthcare is delivered, certainly at the hospital level. But given that we are going to be responsible to a large degree for that whole episode of care, which goes almost 30 days after they've left the hospital, we're not going to have to figure out how to get a little bit of control over what's happening after patients leave the hospital. When they go to the rehab facilities or even to some of the nursing homes, we're going to be penalized for readmissions. We're being, there's penalties out there right now for hospital-acquired conditions, whether it's a urinary tract infection or a central line infection. But the readmission component is a big one, and that's to some degree out of our control, because once these patients leave the hospital and end up in a nursing home, we're not really dictating the care at that nursing home. But in the future, they're gonna have to be partnered up with us, or they're gonna be on a list of who's your preferred people and who aren't your preferred people, because I look now and see where my readmissions are coming back to the hospital, and the truth is, I can spot certain facilities that are much higher on sending patients back to your emergency room than others are, and they're either going to change or they're not going to be players.
I think the tax code changes are going to also contribute to change. And that whole, already starting Cadillac plans that are very expensive, already are being penalized. The cost coming up quickly. So that'll change the attractiveness of different types of health care by virtue of the tax code being modified.
I think we have time for one more question.
With the, going back to some of what we've talked about regarding access, what hurdles do you see in legislation regarding nurse practitioners being able to practice to the full extent of their license?
Actually, I think the hurdles are going down. I think there were hurdles, in terms of how much independence nurse practitioners could have, particularly in a hospital setting. Some of that was generated by just a fear of competition by, the physician community. Others just, sort of a disbelief that, the comment could be, it took me 4 years and this much of a residency to gain the expertise to do this. How does somebody that did 1 year, how do you let them kind of run on their own now? But I believe, particularly with the Affordable Care Act, but the way healthcare is going right now, that mid-level providers, nurse practitioners, physicians' assistants, they're going to have a key role, particularly in those primary care settings, and also monitoring how patients are doing, so that they're not in the hospital. So I would guess that that's going to open up and loosen up a lot in the very near future.
We've seen a dramatic change. If you go back 5, 6, 7, 8, 9 years ago, it's dramatic. I've never seen anything like it. And in fact, it's so dramatic that I'm married to a nurse practitioner. We were married first. Then she came to Monmouth University. How good was that?
I'm sorry, go ahead.
I'm on the board of something called the Healthcare Quality Institute. We have a project that we're looking at right now is to authorize nurse practitioners to have their own practices, to formulate their own firms.
There's a committee in the legislature, the Regulated Professions Committee, that hears changes to licensing statutes, where they talk about the permitted scope of practice, and guarantee that if there is ever legislative changes proposed to expand the scope of one provider group, the affected other provider groups, it becomes a turf war. And so you see, a battling in front of the legislature as whenever there's a discussion about changing the border between what's permissible and what's not by a specific provider type.
All right. Well, thank you to our panel members, and thank you everyone for coming.